Well, hello everyone. My name is Mirvat Alasnag. I'm an interventional cardiologist practicing in Jeddah, Saudi Arabia. I'm here with Radcliffe Cardiology to review some of the most important and relevant interventional trials that were presented at the American Heart Association scientific sessions in 2022. So please join me. The first one was the ECMO-CS, and I think by nature, as interventional cardiologists, when we see patients with advanced shock, we want to help them and improve mortality rates and outcomes. And it's been very disappointing, the previous trials, such as the IABP Shock 2 trial, that showed no benefit in using an intra-aortic balloon pump over conservative therapy. The ECMO-CS was, a glimpse of light, and we were in the hopes that this trial would be positive for patients with advanced cardiogenic shock, that is SCAI classification D and E, or rapidly deteriorating cardiogenic shock. And the hopes was that an ECMO device has a higher performance level and output, and hence the chances of recovery and reversal of shock state and improvement of peripheral perfusion would work. So this was a trial that was conducted in the Czech Republic by our colleagues. It took them about 14 years to recruit 117 patients. And these 117 patients were patients with rapidly deteriorating cardiogenic shock or severe shock, defined by SCAI, as I mentioned, class D and E, and they were randomized to either an immediate VA, veno-arterial ECMO, or an early conservative approach with a view to instate or implant an ECMO device should the patient's overall condition and hemodynamics continue to deteriorate. Now, the endpoint was a composite of death from any cause, resuscitated circulatory arrest, and implantation of another mechanical circulatory device within 30 days. So as I mentioned, they ended up enrolling about 117 patients. 58 were in the immediate VA ECMO group, and an initial conservative group had 59. The mean age was 67 years, and men were about 74% of the total population that was enrolled. Now, STEMIs were about 51%. The remainder were either non-ST elevation MI or very advanced heart failure. Lactate levels were higher in the immediate ECMO arm, 5.3 versus 4.7 millimoles per liter. Mechanical ventilation was required in 74% and norepinephrine in 86%. The composite primary endpoint occurred in 63.8% of the immediate VA ECMO group, compared with 71.2% of the initial conservative group, with a p-value of 0.21. So notably, 39% of the initial conservative group ended up eventually requiring an ECMO. But overall, disappointingly, the ECMO-CS did not show any benefit in early or immediate ECMO implantation in patients with rapidly deteriorating or severe cardiogenic shock. The next trial is really the ISCHEMIA-EXTENded trial. Now, we all know that the initial ischemia trial was published in the New England Journal of Medicine in 2020, where they randomized over 5,000 patients who had proven ischemia, either by SPECT imaging, by MRI, by echo, dobutamine echo, and so on. They were proven to have coronary artery disease. Left main disease was excluded using cardiac CTA, and they were randomized to either an early invasive strategy or a delayed invasive strategy with an initial medical therapy. Now, the revascularization, immediate revascularization, was either by surgical, i.e. CABG, or percutaneous revascularization. And at 3 years, there was no significant difference in the primary endpoint of cardiovascular death, myocardial infarction, unstable angina, or heart failure or cardiac arrest. There were also very similar rates of death in both arms. The extended looked at a longer period. Overall, the baseline characteristics of 5,179 patients were looked into. The median age was 69, and 23% of whom were women, 16% Hispanic, and 4% Black. 42% of these patients were diabetic, and the median EF was 60%. So remember, the ischemia trial excluded patients with advanced heart failure, with refractory angina, with a severely impaired LV systolic function and an ejection fraction of less than 35%, as well as patients who had prior coronary artery bypass grafting. A total of 557 deaths occurred over a median follow-up of 5.7 years, with 288 of these added in the extended follow-up phase. There was a total of 343 cardiovascular deaths, 192 non-cardiovascular deaths, and 22 were unclassified deaths. All-cause mortality was no different between the randomized treatment groups. The 7-year rate was 12.7 in the invasive and 13.4% in the conservative arm, with a confidence interval of 0.85 and to 1.18. There was a lower 7-year rate of cardiovascular mortality, 6.4% versus 8.6%, with a confidence interval of 0.63 to 0.96 with an initial invasive strategy, but a higher 7-year rate of non-cardiovascular deaths occurring at 5.6% versus 4.4% in the conservative arm. There was actually no heterogeneity of treatment evident in the pre-specified subgroups, in particular multi-vessel disease patients. And how much the significance of having a slightly lower cardiovascular mortality in the revascularization arm is not well understood. Why there is a higher mortality in the non-cardiac mortality in the initial conservative is yet to be known. Perhaps it's cancers and due to being unmasked by antiplatelet therapy, as has been theorized in the past. The next trial is really the RAPCO-RITA trial. Now, this is an interesting study that really looks at patients who require coronary artery bypass grafting with an initial graft, the left internal mammary artery graft, going to the LAD, and then the remaining vessels, what do you do with them? So they were randomized into radial artery versus a saphenous vein graft. And the goal was to evaluate the radial graft compared with the saphenous graft in those who were undergoing coronary artery bypass grafting. It was randomized. It was a parallel design, and patients were randomized 1-to-1 with in the radial arm, they ended up with 113 patients. In the saphenous vein graft, they ended up with 112 patients. And the left internal thoracic artery to the left anterior descending artery was a prerequisite for enrollment in this trial. So they ended up with 225. The duration of follow-up was actually very robust, 16.5 years. The mean age was 73. Women constituted only 19% of those enrolled, and diabetics were 46%. Inclusion criteria were age over 70 or 60 years with diabetes, undergoing coronary artery bypass grafting with 2 vessels at least. Exclusion was those with small radial arteries or poor flow in the ulnar artery. Interestingly, they evaluated the radial artery with tests such as the Allen's test and so on, which largely the interventional community has moved away from, and they're using more like ultrasound assessment of these arteries. The main findings were the primary outcome of all-cause mortality, myocardial infarction, repeat revascularization occurred in 60.2% of the radial artery bypass group versus 73.2% of the saphenous vein group, with a p-value of 0.04. Secondary outcomes were mortality of 52.2% in the radial artery group versus 63.4% of the saphenous vein group, with a p-value of 0.08. Repeat revascularization was 10.6 versus 16, and with a p-value of 0.13. So overall, it appears that radial artery conduit perform better with better outcomes compared with saphenous vein grafts, and are highly recommended in patients who are suitable and have suitable radial arteries. This begs the question of who does the radial artery belong to? Does it belong to the cardiac interventional cardiologist? Does it belong to the cardiac surgeons? Does it belong to the nephrologist? It really belongs to everybody, and we need to learn how to communicate. The issue here was these are radial artery. The recommendation is to use it in suitable ones that were not did not have compromised flow and radial artery obstruction or occlusion following percutaneous interventions or even diagnostic caths. I think what it means is interventional cardiologists need to perform more safe radial accesses, perhaps with ultrasound guidance and generous vasodilators to prevent spasms and so on, and heparin use. But it also perhaps means that we need to be assessing radial arteries more robustly, and we need trials that look into radial artery occlusion rates a little closer now that we are going to be using these radial arteries more frequently, both in the interventional space and in the surgical space. The final trial that I'm going to wrap up with is the PRECISE trial. This is a very interesting study that really looked at patients who had chest pain, stable chest pain. These were not patients who had an acute coronary syndrome, meaning unstable angina or myocardial infarction, and they underwent either a usual pathway versus a more precise pathway that was based on risk stratification. The results from the PRECISE found a personalized, more precise testing approach led to a more efficient evaluation of cardiovascular disease risk and improved diagnosis and treatment of coronary disease in over 2,000 patients with stable chest pain. Of note, about a quarter of the patients who were evaluated in this trial in both arms had what we call typical chest pain or cardiac chest pain. The current guidelines, chest pain guidelines that were published recently, recommend that we move away from the nomenclature of typical versus atypical and really to use the word cardiac versus non-cardiac and to try to diagnose non-cardiac chest pain. So here, the cardiac chest pain was about a quarter of the patients who were enrolled. So investigators here, as I mentioned, compared a strategy of initial risk screening with delayed testing for low-risk participants and using cardiac CT and CT FFR for all others to a strategy without initial screening and immediate testing for all participants. And I think what this really does suggest is that stratifying our patients and streamlining it is going to be important in the upcoming years. The average age of these patients who were enrolled was about 58. Women were about 48 to 50% of the enrolled population. Hypertension, 61%, diabetes, only 17%, and the chest pain, as I mentioned, typical or cardiac, was only 24% in both arms. So the precision strategy is now a preferred approach in evaluating patients with stable symptoms and suspected coronary artery disease. Outcomes were improved using deferred testing with qualitative determinants such as CTA with selective FFR-CT in that group. So thank you very much for joining me, and I hope this was an adequate summary for you.